Hello, everyone, and welcome to the webinar, A SANE Approach to Human Trafficking Cases. Today's program is presented by Equitas and presented by Jane Anderson and Kim Nash. My name is C. Ross, and I'm an administrative associate at Equitas, and I'll be moderating today's webinar. If you have a question during the presentation, please enter it in the question and answer box. We will answer questions periodically throughout the webinar. You are also welcome to contact us directly at any time following today's presentation. We will send you contact information during our follow-up. Next slide. Equitas's mission is to improve the quality of justice in sexual violence, intimate partner violence, stalking, and human trafficking cases by developing, evaluating, and refining prosecution practices that increase victim safety and offender accountability. As a national training and technical assistance provider, Equitas develops resources, conducts trainings, and offers 24/7 consultations for prosecutors, allied professionals. For more information on Equitas, please visit our website at equitasresource.org. You can also follow Equitas on Twitter, Facebook, Instagram, and LinkedIn. The link to each is available on our website. Today's webinar is supported by the U.S. Department of Justice Office for Victims of Crime. The information presented in today's webinar does not necessarily reflect the views of the Office for Victims of Crime. Presenting our webinar today are Jane Anderson and Kim Nash. I will now turn it over to Jane and Kim.
Thank you, C. Thank you, everyone. I'm loving seeing you're literally in all points of the United States so far. I saw one from Maine and then quickly one from Hawaii. So we've got it covered. I'm Jane Anderson. I'm an attorney advisor with Equitas, and I'm a former prosecutor, having tried human trafficking cases for several years in Miami, Florida. Hopefully, I bring that experience to my role as an attorney advisor with Equitas, where I provide training and technical assistance. And my favorite thing to do, of course, is to work one-on-one with you all in the field that are dedicated to improving your response to both sex and labor trafficking. And I have to admit, one of the biggest game changers for me was when I met the illustrious Kim Nash and really started thinking about the value, not only to the victim survivors that we serve, the value of providing them accessible medical care, but also the impact it can have on our human trafficking response, sort of more practically by collecting more evidence, documenting additional statements that may be admissible, and just educating ourselves really about the long-term and short-term impacts of sex and labor trafficking. So I'm very, very excited to be here with Kim. I'm going to let her introduce herself and we'll get started.
Hi, everyone. Thank you so much for being here with us today. And thank you to Equitas and C and Jane for inviting me. I don't say this about every group I work with, but Equitas is one of my all-time favorite organizations to work with. And they're also one of the organizations that I am most often referring criminal justice community partners that I work with to for assistance and resources. I live in Colorado. I've been a nurse for 24 years, and I have been in the specialty of forensic nursing for the last 16 of those 24 years. I have a great passion for providing healthcare for patients who have been impacted by violence. I have a passion for providing that care to all genders and all ages. And I just love when we come together for education, because not only are we passing along information, but we're learning as we do so. So thank you for having me here today.
Thanks, Kim. I want to just acknowledge that Kim and I have been working together for years, and some of that was in collaboration with the International Association of Forensic Nurses. And so I want to acknowledge their contributions to the material that we're providing today. And I also thought that Kim, you might be able to share a little bit about what IAFN does, and if there are folks in the field out there who may want to use some of their resources.
Sure. So IAFN, the International Association of Forensic Nurses, is a membership organization that I have been a member of since the day I took my first class on the specialty of forensic nursing. I had the honor of working for them as a forensic nursing specialist for 6 years and consulting on many projects and grants with them in addition. So I now work on an OVC grant in Colorado, but I rely heavily on IAFN as an organization and resource. There is a plethora of benefits to being a member. What a lot of people don't know is that they provide a lot of resources and assistance for people who are not members, and that includes community partners. So I encourage you to check them out at forensicnurses.org. They have some great position papers. They have a great strangulation resource tool, as well as classes that you can attend.
Thanks. So our objectives today, this webinar actually is part of our series through the OVC funding, really asking prosecutors to take a more active role in shaping their community's response to human trafficking. We recognize that prosecutors can impact how cases are handled from really beginning to end because of our role as leaders in the community. So one of the things that Equitas wants to elevate is how do we as prosecutors identify, recognize, and then elevate the role of the SANE or the medical profession more generally in our trafficking responses. So our objectives today will be to identify how we can enhance those prosecutions, what it looks like when victims or survivors are provided access, meaningful access to healthcare, where we're documenting those injuries, where we're documenting their medical history. And in order to do that, I think we all need to get a better understanding of what the role of a SANE is, because I think it's broader than most of us realize. I know I can say honestly that I didn't understand while I was working as a prosecutor, the extent of care, information and expertise that our SANE partners have. So let's see if we can articulate the role that they play and kind of walk through what that medical forensic exam looks like. And then ultimately, how do we present this at trial, both from a fact-finding position, but also perhaps through expert testimony. So I want to see from you guys, how would you describe the level of integration that medical professionals have in your human trafficking response? And that can be anything from, the SANE is part of our protocol. Every victim survivor of human trafficking we interact with, we provide access to a SANE, to when we believe there is going to be forensic evidence that would be relevant to our case, then we're providing access to a SANE so that we can get sort of maybe a sexual assault kit initiative, or it's really dependent on a case-by-case basis. So we're getting a couple of folks kind of chatting in, and I encourage you guys to keep those thoughts going in, because we do see that this is maybe a gap, that it might be written into a protocol, but you may not have access in your communities, or law enforcement really isn't thinking about this because they're thinking about SANEs only in a limited role of maybe collecting relevant DNA evidence. So looking forward to seeing more of the chat there, but I'm gonna spend really the first half of this webinar picking Kim's brain, to be honest. So if you don't mind, can share with us sort of this healthcare infrastructure within which SANEs and our allied professionals and community professionals are working.
Sure. So unfortunately, care of victims of violence, such as sexual assault, intimate partner violence, human trafficking, that has been severely lacking in medical schools and nursing schools. So we encourage clinicians working in healthcare settings who may have contact with these patients, which in essence is 100% of clinicians, to seek out education if they haven't done so already. So if you're not aware of the acronym SANE, it stands for Sexual Assault Nurse Examiner, which is really a subset of a forensic nurse. You may live in a community where you have sexual assault or forensic nurses or clinicians. It doesn't always need to be a nurse. It can be a physician assistant, a PA, an NP. But if you don't live in a community that has specially trained clinicians for these situations, then I encourage you to get together a group like prosecutors, law enforcement, leadership, and approach a hospital or a clinic setting and ask for assistance in designating some clinicians who would be willing and interested to become trained, because every community deserves examiners who are able to help respond to this type of violence.
Yes. And thank you for acknowledging that, we're using a particular acronym. I mean, to be frank, it's because the title's catchier. When we say sane response, but it is wider than that, and there's going to be different language that you may be using in your communities. So thanks for that.
Sure.
So give us the definition, and I know we've recently we've updated this a little bit about what the current definition of forensic nursing is.
Yeah, it really is specialized care. So when we think about other specialty areas of healthcare like labor and delivery, emergency department, cardiology, forensic nursing is a specialty nursing area. There are forensic nurses that deal in death investigation, but the vast majority of forensic nurses out there are trained to deal with living victims of crime, patients who are seeking health care because of violence that was committed against them. This can span the lifespan. So some forensic nurses work with patients across the lifespan from infancy to older adults, and some may only be trained in pediatrics or adults and adolescents. But really, it's addressing the health consequences of the violence that that patient has experienced. Of course, there are criminal justice components that are a benefit of that care provided, but really our role is to look at that person, that patient in front of us, understand what happened to them and how that impacted their health in a negative way so that we can help provide interventions to alleviate the negative health outcomes or to help prevent future negative outcomes. With any type of violence that a patient experiences, there are going to be potential short and long-term health outcomes. And it's very dependent on that patient, what health status they had prior to the violence, what happened to them, and really what resources and interventions are offered to help alleviate those future health problems.
So this is sort of that that macro lens onto what forensic nursing encompasses. But I want to get a little bit more in the weeds when we say, what is the role of the SANE? And right off the bat, I want to acknowledge that collecting forensic evidence is one of those roles. And I think law enforcement hyper focuses on that role. And we don't consider all of the other things that you're providing to your patients every time that you interact.
What we really want the criminal justice professionals to understand is that, yes, we do collect forensic evidence, but it's so much more than that. If you have a patient who has experienced trafficking, whether it's sex trafficking, labor trafficking, or a combination, a sexual assault patient, and they are outside of your jurisdiction's evidence collection protocol, an exam is still warranted for the actually two simple reasons. The first overriding one is that health consequences don't disappear just because you're not collecting evidence. Those same health consequences are there. So we want those patients to get the health care that they deserve and need. The second thing is, just because you're not collecting a forensic sample doesn't mean that you're not collecting evidence. And we'll talk more about that as we go through a medical forensic exam, because all of the care that we provide can become evidence. All it takes is a subpoena. And what you have then is you have a patient who has great health care provided, but you also have a medical professional that you can use during the investigation, as well as during potential prosecution.
Mm-hmm. And as I already mentioned, SANEs and allied medical professionals are also incredibly important in a multidisciplinary setting to provide education to others. To let us know about some of those consequences, because we may be able to use that as part of the presentation at trial to make it more impactful. And of course, the testimony as the fact witness that provided the care, and also the expert testimony about findings, and of course, even further afield, some other expertise that we'll talk about. So let us talk about some of those medical consequences that you are seeing as the medical provider. And we do want to talk about both sex and labor trafficking. Equitas, we tend to focus more on adult victims, but also thinking about the adolescent victims of trafficking as well. So those of you on the call, if you want to share with us things that you have seen, but I'm also going to have Kim walk through some of these health risks, some of them more obvious than others, I think.
Yeah, I think that it's really easy for us to think about sex trafficking and understand that we may have health consequences like pregnancy, HIV, hepatitis, sexually transmitted infections. It's very easy to understand some of the psychological trauma that goes in, that plays into it as well. It is such a serious long-term consequence of violence. Looking at what some of you are putting in here, but I want you to think more individually when you can think about victims of trafficking you may have interacted with in your professional role. What are some of the consequences that you've seen? And not leaving out labor trafficking. So if you've got somebody who has been trafficked in an agricultural area and they're out in fields, farm work, they're going to have some pretty serious health consequences too, from the type of work they're doing, the lack of access to healthcare. They may have potential skin cancer problems or eye and vision problems from lack of eye protection during some pretty harsh environments. Same thing with pesticides that are breathed in, absorbed through skin, through mucous membranes. So when we look at what happened to the person and we take into account what their previous health status was, you may also be getting into some conditions that are exacerbated because of the trafficking that they experienced. So someone who is a diabetic and is not provided the medication they need. Is it possible that they have vision changes? Is it possible that they have some neurological problems or perfusion problems with their extremities, meaning that they start to have gout in their feet or ulcers on their feet from lack of medication? These are not things that we typically think about when we're first interacting with a trafficking patient, unless we've had specific training on it. So I encourage you to really investigate what is out there in your community. What are your clinicians comfortable with? And if they're not comfortable and they need education, reach out to Equitas, reach out to me, reach out to IFN. There are good trainings out there. But this is why it's so important to look at each individual person. And you can even have, say, human trafficking raid that yields a group of people who have been victimized, but each one, say you've got 10 of them, each one of those 10 people needs to individually be assessed because their consequences, they may have some similarities, but they're probably going to have some big differences too. Mm-hmm. You can read here all of these short and long-term possible physical manifestations, and these are just some of them. We can't put a list on a screen in front of you of all the potentialities because there's just so many of them.
Mm-hmm. And the psychological consequences as well, and how that may come up in the work that you're doing, treating a particular individual patient.
Sure. And you just take a look at this list here, and this just scratches the surface, as we all know. And would any of us, when you think about the difficult patients that you've taken care of, or the difficult victims that you've interacted with, whether it's from an investigation standpoint, or you're getting ready, prepping someone for trial, these types of things we're looking at on the screen in front of us make it very difficult to interact with these people. It makes it very difficult for us to get the information we need to do our job. But we must remember that we're experiencing these types of things because of what the perpetrators, the traffickers, chose to do. These are not choices that the clients, the victims, the patients in front of us are choosing to have. They are a result of what they experienced.
We've obviously trained a lot, Kim, because that's, one of Equitas's favorite things to remind folks of, which is that some of the real and consequences of trafficking, of having experienced trauma, are sometimes inconvenient for law enforcement and prosecutors. And that's not to the fault of the victim, survivor. That is the fault and direct result of the offender, the defendant. And so to keep that offender focused, keep that focus all the time while we're interacting with victim survivors of incredible physical and psychological trauma. So always a good reminder there.
And sometimes we need to remind the people we're interacting with. A forensic nurse or a SANE who's been doing this for a while understands that sometimes we may need to say to a patient, I understand that you're experiencing what we call hyperarousal, or whatever it is on this list. That's a very normal reaction to an abnormal thing that happened to you. And I'm sorry that you're here having to make these decisions and experience this type of exam because of a choice that somebody else made. You didn't make the choices to be here. Somebody else made the choices for you to be here. And I'm sorry that you have to make these decisions.
And that's a great example of one of the benefits to the victim that this SANE exam and this medical care can be, which is the educational aspect of it, right? Because victims of trauma don't necessarily know why they're having these trauma responses. And it can be when we work with survivors, they'll often share that when they started learning about common responses to trauma, common outcomes or risks of their trafficking experiences, they started being able to put the pieces together, and it actually was very healing for them to have that education.
Yeah.
So you're going to do the one side of the slide, and then I'll do the other side.
Perfect. We haven't really touched on substance abuse, how difficult it is to interact with somebody who's addicted to substances. But when we think about the why that substance abuse is a coping mechanism, if you had to get up and live through the horrors of trafficking, becoming addicted to substances is an effective coping mechanism to stay alive and make it through a day, whether that's by choice, whether it's by force, whether it's a combination. It is a coping mechanism. It's not a healthy one, but it may be the only coping mechanism that person has access to. The benefits of a medical forensic exam for the patient or the victim is medical care. We can initiate the beginning of the medical care that they so desperately need. We can educate them, like Jane said, about what's going on with their body, what's going on with their mind, what's going on with their reactions that oftentimes seem so counterintuitive to us. Well, some of the reactions seem counterintuitive to the patient too. They don't understand why they're reacting. They don't understand why they're numb and they're not feeling things, or whatever it is that they're experiencing. We can get them set up with medication that they may have been denied access to or that they need because of what's been done to them. We can assist with the beginning of some safety planning. And I want people to understand, whether we're talking about trafficking or intimate partner violence, those victims who return back to the trafficker or return back to the abuser, that doesn't mean that we failed on our part. If we're educating, we're providing non-biased care, we're talking about safety planning, sometimes they may be returning because that is the safest thing for them to do. Each time we provide an intervention, whether it's a nursing intervention or justice intervention, that is something that they're experiencing and they can fall back on, and it is a win. So I know that we want to keep these victims away from their traffickers. When we're not able to do that and the victim isn't able to stay away, that doesn't necessarily mean that we failed at our job. And I think we all need to keep that in mind. The other great thing about an exam is continuing access to services. When we work together as teams, even though we have different roles, and we demonstrate our trust in the system to the patient, we are building that reinforcement that the system is there to support them. Jane, I'll let you talk about the criminal justice side.
Yeah, I just wanted to say, because it came out of a recent conversation, I'll plug one of Equitas's other initiatives, which is our Just Exits initiative. That one we work with a 8-member advisory council who share their professional and lived experience with criminal justice professionals to enhance the response. And one of the things that we hear very commonly is, there were people along the way that really made positive impact on my ability to eventually exit the trafficking situation. And they probably never know because it wasn't an immediate response, but they still was this positive impact along the way of knowing, this is a safe person, this is a safe place, and kind of keeping that in their back of their mind for a later date, and then maybe accessing that system again. So I'll just validate what you were saying about, us maybe not being the intervention that shows immediate consequences that we can see impacting a victim's ability to leave or exit a trafficking situation, but it still can be to that individual very meaningful and impactful.
Absolutely.
So from the law enforcement perspective, we're always talking to law enforcement about how key it is to build that trust, build that rapport. And one of the ways that we can do that to demonstrate that we're not just here to get something from you. We're not just here because we want to make our case, we want to get our conviction, but we truly and genuinely care for your well-being and your safety. Nurses have for years always been voted the most trustworthy profession in the United States. I haven't seen recent data, but I would suggest it's probably still up there. So if we're able to provide victim survivor with that meaningful access to medical care, where we're saying, hey, let's just take care of you first. Let's figure out if you need any medication, how you're doing. We'll do that. We'll deal with that first. So it demonstrates. And then of course that goes a long way to build that trust. Now, from a more maybe cynical point of view, it's always great when it's the right thing to do, and it can also benefit your investigation and your prosecution. And what we know is that some statements that are made in this setting would be admissible as exceptions to hearsay under the medical hearsay exception. So we'll dive a little bit deeper into that in a bit. And also the collection of evidence, whether that be a collection of a DNA sample that ends up being relevant, or the documentation of injuries. That also, of course, is going to improve our investigation and our prosecution of an offender.
Yeah. And I do the two things that we do need to address throughout the entirety of this session is lack of injury doesn't mean that you shouldn't have a medical forensic exam. I think any prosecutor would say they would love to have a forensic clinician in the courtroom to explain why there's a lack of injury and why violence still occurred despite a lack of visible injury. And same thing with evidence. Let's say a whole kit is done on a sex trafficking victim and there's no DNA evidence there. Well, you've still got that medical professional to explain why. Well, why does it make sense that there is no DNA evidence there, yet we still believe that the history that this victim is giving us is consistent with what the exam showed or didn't show.
So I love how we use the language, and hopefully we're consistent here. And it's important down the line, if we are using that medical exception to hearsay, that we talk about the primary role being the care for the patient and the value of that, and what you're able to do Kim, that law enforcement is never going to be able to do, because your role is distinct in the fact that you're there to care for a patient ultimately.
Yeah, we're really one of the luckiest members, disciplines of that multidisciplinary team in your community, because we don't have to worry, does my patient feel uncomfortable with me calling them a victim or them a survivor, because everyone I'm interacting with as a nurse is my patient. So I feel very lucky and comfortable in the fact that I can call everyone a patient. And really, you need to assess, if you've got forensic clinicians in your community, do they believe that too? Do they believe that they're there providing care for the patient? The vast majority of us do. Once in a while, we still hear about clinicians who really view themselves as evidence collectors. And while that might be okay for them in their position in community, it really is a disservice to the patient and to the community response when there isn't that global response to the healthcare side of things. So I would encourage communities to really assess that, or if you're utilizing clinicians, to assess what their foundational beliefs are when they're caring for these patients. Nurses are really good at quickly building rapport. We are usually good at building a physical rapport with patients. We are usually good at talking about difficult things. Bodies don't embarrass us. Certain body parts don't embarrass us. And when you're with a person who is saying to you, I'm here to care for you, and I need to know a little bit about what happened to you so I know how to determine the best plan of care for you, that immediately sets up a safe place for some potential disclosure. And I think it's important that when we're talking about disclosure, when we're getting medical history, that if law enforcement has already interacted with a victim, or maybe a forensic interview has been done with a victim, and this person comes in for an exam and we get further disclosure, that is not demonstrating a poor law enforcement interview or a poor forensic interview. It's actually the opposite. It's demonstrating that that patient is going through their course of disclosure, and everything that's happened up to that point has gone really well, because we all know that people disclose delayed oftentimes and in pieces oftentimes. So I once in a while still see some communities who struggle with the nurses or the clinicians asking further history when there's already been an interview or a forensic interview. And I really encourage communities to let those clinicians ask the questions they need to for the best type of exam, even if it runs the risk, and is it really a risk, or the potentiality that there may be some further disclosure.
I hear that too, Kim. And I think, it comes from a place of wanting to preserve the integrity of our case and wanting to hold offenders accountable. Because in our careers, if we haven't always done cases involving domestic violence, sexual violence, and human trafficking, this idea of having an inconsistent statement can be kind of terrifying for the prosecutor. And so I will say to the prosecutors, it's not the victim's responsibility. The victim should not be denied access to meaningful health care. And that is, you need to have a history to provide that meaningful health care to save our case, A. And B, there's lots of strategies to kind of introduce that evidence, not as evidence of inconsistent statement that should be read as the victim not being credible, but an inconsistent statement that actually means this statement became richer when trust and rapport was built, when trauma was addressed. And this is actually evidence of trauma, thereby evidence of trafficking. So it's incumbent upon the prosecutor, not the victim, to strategize how we're going to deal with these, what might be at first blush a kind of a fearful, oh no, we have an inconsistent statement.
Correct. Yeah. Yes, and so there's lots of things that happen with the patient in our exams globally, connecting not just to criminal justice, disciplines, but also referrals to other healthcare providers, whether that's mental health or physical health needs that they may need.
Yeah. I do want to ask you a little bit about consent, how you talk about it, and at what different stages you might be asking for consent.
So all of us have probably had experience where we go into a healthcare setting and we have to sign a form for consent. And so many of us think of consent as this one thing that we sign and it's done. But in healthcare in general, and especially in medical forensic exams, consent is not a thing you just check off at the beginning and then you can proceed. Consent is a continuous process. So when I have patients sign consent, I make sure they understand, here you're signing saying it's okay for us to proceed with an exam. Just because you're signing here doesn't mean that you are obligated to do everything I'm going to offer. And I will explain it. Some of my patients choose to do everything I offer. Some choose to do nothing that I offer. And some choose to do some of the things that I offer. We are here to support you in your choices. And clearly, we all know that what we're attempting to do with that type of consent is to return some semblance of power and control back to that patient. Now, trafficking patients, we need to be a little bit careful with this, which is, I don't know if I'm phrasing this right. It's a bit of a tricky thing I'm trying to say. I'm not saying to not give trafficking victims consent, because they absolutely need to consent to every piece. But we do need to understand that that can be a little bit overwhelming, especially for a victim who has been trafficked for a long period of time. All consent has been taken away from them. They have not been allowed to make any type of decision about themselves or for themselves. So to do these choices in small pieces, in a gentle way, in a non-confrontational and a non-rushed way, to give the choices and sit back, let the patient think about it, and let them know they can change their mind. Sometimes providing gentle rationale for each choice, the pros and cons of each choice that they're making, that's okay too. And if a patient declines to do something that you're offering, reminding them that they can change their mind, whether it's later in the exam or the next day or the next week, they can always come back and opt for some of those choices at a later time. So some examples may be that a patient comes in and they want a medical forensic exam, but they don't want us to collect evidence. And you may think though, well, what situation would that ever be in? And I can tell you I've been in that situation for I see there's a few nurses on this call as well. Typically that might be an adolescent who doesn't understand that they're being trafficked, that they have been very manipulated and coerced by somebody that they think is a boyfriend. But we as adults and professionals understand that this is absolutely a trafficking situation that this adolescent is ensnared in. And so in that case, if they're like, I am not having an exam and you are not collecting evidence because this is my boyfriend and we're running away and going to live happily ever after, I'm going to say, I'm not collecting evidence if you don't want me to. I legally can't do something you don't want me to, but I am concerned about your body and health. And so why don't we talk about what type of sex you're having and how you're protecting yourself and your knowledge about your body. And I just want to make sure that your body's okay. And we may proceed with an exam without evidence collection. A patient in some jurisdictions, some territories, some states, depending on the statutes there, many patients have the option to have their evidence tested or stored. Some of them have the option to remain anonymous and not report. All of those options are designed not to hinder the criminal justice system, but to give patients a choice to come forward, get the medical care that they need, get evidence collected that may otherwise disappear, and so that they can make choices at a later time. In the states that don't have anonymous options, there are probably patients who want to come in for medical care and evidence, but they're too afraid of the criminal justice response, and so they don't. And we're failing those victims, and we're in essence failing the criminal justice system, because then we haven't collected what could very well be needed in the future.
Mm-hmm.
And it is very state and jurisdictional specific. territories, tribes, everyone needs to just know what their victims' options are.
Mhm. And I'm sure that we could help you if you're looking to figure out what it looks like where you are.
Mhm.
So
Absolutely. Equitas is great, a great resource for that, as is IAFN.
So let's walk through, we've got it as sort of 5 steps of the medical evaluation, starting with the history, going on to a general exam, a more specific physical exam, some laboratory when appropriate, and then this idea of documentation, diagnosis, or interpretation. So I'm going to have you go through it sort of one by one, starting with the medical forensic exam.
Yeah, so that previous slide was kind of like this broad skeleton of what we're able to offer. And then you take the patient that's in front of you, what parts here are going to be applicable to them. A history is going to be applicable to everyone, a general physical exam, as long as they consent to it, applicable. But then what are the specific assessments for this patient that are going to be helpful? What are the specific diagnostic interventions, whether that's labs, x-rays, CAT scans, vision tests, danger assessments, strangulation assessments, sexual assault assessments, those types of things would fall into the diagnostic category. And then, of course, all nurses are going to be documenting their interaction and coming to some form of conclusion or interpretation. So at the next slide, this is more the way I explain things to a patient when we're first interacting with them, what many nurses do. And of course, we all have our own process, but in general, we're saying to a patient, what an exam encompasses is us talking. I need to know about your medical history. I need to know a little bit about what's been happening to you so that I can do the best medical exam possible. Knowing your medical history and what's happened to you to bring you into the exam room today will help me develop this medical plan of a care, what type of exam we may need. Now, during that exam, we may be collecting evidence if you're within evidence collection time frame, if it's appropriate, and if it's okay with you. We may be doing some photography as a form of medical documentation with your consent, and patients can consent to all photos, they consent to some photos, and they can say, I don't want any photographs taken, which is really important for us to remember. In the cases where patients may choose not to have photography, we need to remember that photography or videography are oftentimes a part of the abuse that they have endured, and image creation can be a very traumatic thing, even when it's in a non-traumatic setting. And then, of course, medication interventions, depending on what their history is, coupled with our physical exam. Are there medications that may be appropriate for us to offer the patient, or prescriptions that may be appropriate? And then, of course, discharge planning. What community resources are out there? What does the community have to assist this patient? What are our safety issues? And is this patient returning to an abusive situation? Are they attempting to leave an abusive situation? Or have they successfully left, but they remain in danger from the abuser or abusers? Those types of discharge plannings are going to look very different depending not just on the patient in front of you, but where they're going when you discharge them out of your exam room. We don't spend a lot of time on this today, but it is imperative that we mention it several times on the importance of an advocacy response. And that is a large part of a forensic nurse's interaction with any type of patient who's experienced violence. We want them to have access to systems-based advocates who can help them navigate the criminal justice system and access some of those resources through the systems. But we definitely want them to have a confidential advocate connection as well, because these are the people who are going to be helping them navigate their life, the system, and they are the entity that is most likely to keep that patient engaged in the criminal justice system. And really, they not only help the patient, but they help the rest of us do our job so much better. I believe that one of the most important interventions I can offer any of my patients is access to confidential advocacy. If you happen to be in a setting where the healthcare entities are not allowing confidential advocates into the exams, reach out to IAFN. We have a great position statement on the use of advocates for all victims of violence. When I first talk to a patient about their medical history, it's a really easy place to start. What medical history they have. Have they been diagnosed with any chronic or long-term conditions like asthma, diabetes, heart disease, whatever it may be? We're recording those chronic conditions and what was the status of that condition prior to the trafficking that took place. Are they taking any medications, or should they be taking medications that they don't have access to? Are they able to take those medications regularly? And do they have access to ongoing medications should they need it? Have they had previous hospitalizations, surgeries, or injuries? Have they had experienced injuries that they were not allowed to seek or not able to seek healthcare for, that have healed improperly, that are now causing problems? And then we're really just gathering a picture of that patient's overall health status to assist us in identifying what possible impacts the trafficking has had and may continue to have on that patient's well-being. After that, we also will ask about allergies and immunizations. Then we get more into the assault history. For a patient that we're interacting with a sexual assault that's not been trafficked, we really focus on that sexual assault history. This is a little bit more difficult for a trafficking patient. Sometimes the assault is so, like, how do I tell you what the assault was when I've been trafficked for the last 8 months or 2 years or 8 weeks? There's so many assaults that can occur in that time that this can be a really overwhelming question for a trafficking patient, a patient who's experienced trafficking. So each nurse, each clinician is probably going to have their own approach for this. It may be screening questions at first, and then we ask for a little bit more detail. We've built a rapport with this patient already, so it may be asking the patient, can you tell me a little bit about what's been happening to you, so that I can help narrow down what type of assessments might be appropriate. And so it may be more of an interaction, and then it may be talking about just tell me about the most recent experience that you've had, especially with perhaps a sex trafficking patient, to get at a timeline for, are we in the window of opportunity for preventing HIV or pregnancy or evidence collection? So this, when we're talking trafficking patients, it's a little bit different than when we're talking about a standard, and that's a terrible word to use, but a patient who's experienced sexual assault where there isn't a trafficking component. That's a longer but probably more appropriate way to say it. We are looking for some acute things. Is there pain? Is there bleeding? Is there an emergency medical condition that needs to be addressed before we can get into kind of the bulk of our medical forensic exam?
And Kim, you do such a great job of explaining the purpose behind the assault history. But for those of you out there that might be thinking down the road about the prosecution and the testimony that comes out of it, you may not be working with a SANE that can articulate it as well as Kim, but it's going to be really important for you to be able to be successful in articulating why this assault history is hearsay, medical hearsay, necessary for the treatment or diagnosis. So Kim is really great at being able to say, I need to know what happened so that I could narrow down my examination and my treatment to you. But that's the connection. You're going to have to make sure you explicitly are able to elicit to make the arguments about the hearsay exception.
Absolutely. And for those of you who are maybe interacting with a clinician who looks and sounds very uncomfortable with what they're explaining, we can connect to Equitas, and IAFN can assist with some testimony prep. So again, we'll talk about it a little later, but one of the many reasons for that pretrial prep being so important with your healthcare witnesses. So The physical exam, there's several components to it and is really tailored to what that patient has experienced and what they may be at risk of. So of course, you're going to have the nurse or the clinician in the room along with the patient, and the patient has the right to have a support person there. That may be somebody of their choosing in their circle of people. It may be an advocate. It may be that they don't want anyone in the room, but we do need to be acutely aware of a patient who is displaying nonverbal cues that the person they want in the room is really wanted in the room, because traffickers come in all shapes and sizes. They come in all genders. They come in all relationships. Let's say you're working with say a 12-year-old trafficking victim, and it could be younger. Let's say a child trafficking victim who's there with a parent. We need to remember that this parent could be one of many different relationships. It could not be a parent, and it could be a trafficker. It could be a parent who is unaware the trafficking is happening. It could be a parent who is the trafficker. They are trafficking their child. It could be a parent who is aware of the trafficking but not doing anything about it. Or it could be a parent who's being trafficked themselves. Like you've got to look at this global picture of all of these things could be a possibility, and I don't really know what the answer is. So making sure that patient really does want somebody in the room, and not saying you're allowed to have somebody in the room when there's other people there, saying that alone with a patient and saying, if you don't want anyone else in the room, I will say you're not allowed to have anybody else in the room, so that the anger and the comes down on me and not on the patient. We do focus on the entire patient, meaning if this is a patient who's experienced sex trafficking, we're not going to just look at their genitalia. All forms of violence have global impact on a person's body, and so we need to be focusing on all systems. A prepubescent sexual assault exam is very different than one that is performed on a patient who has reached puberty. So for a female patient, or a patient who has female genitalia, who has experienced some sort of sexual abuse or assault, if they haven't reached puberty, nothing is going inside of them, not swabs, not medical devices like a speculum. If there was a medical necessity for that to happen, say there was genital bleeding on a prepubescent patient, or there was a suspicion that a foreign object was left inside of them, that would be done under sedation. And the rationale for that is prior to puberty, the tissue that surrounds the vaginal opening on female genitalia is very sensitive to touch, meaning a swab or a medical device would hurt. Once you reach puberty, when you have female genitalia and your body is releasing the hormone estrogen, it changes the appearance of that tissue, the hymen that surrounds the vaginal opening, and it decreases the sensitivity. That's why adolescent and adult patients who have female genitalia can tolerate swabs and speculums, and prepubescent children cannot. We're documenting all physical assessment findings and injuries, and we're explaining the exam to the patient as we go along and asking permission for each and every step. Again, remembering consent is an ongoing process. It's not just them signing a legal document at the beginning of the exam. It goes from the initial interaction all the way until the last interaction. As we're doing our physical assessment and documentation of findings, we're also teaching about the body. We're asking questions. We're continuing to rapport build, and we're talking about wraparound meaningful services, which may be criminal justice services. It may be advocacy. It may be healthcare. It may be housing, safety, counseling, other medical testing and care that may need to be done. But we're really wanting this patient to get the services that they need to be successful in their healing.
This is another place where you may, as the prosecutor, really have to work to educate your judge, particularly your judge or your fact finder, that this is part of the medical exam, this discharge planning, this follow-up care, these referrals. This is part of the care that is provided in a medical setting. It's not something separate and distinct from that. And we'll follow through with that in a minute. But overall, the biggest thing that you need to relate and sometimes demystify is that the SANE or the person that is in that role that may be collecting evidence as part of their medical forensic examination, their primary job is to provide patient care. There are, and I think, Kim, you highlighted, there are certain folks that maybe fall outside of this, where they really are much more of an evidence collector, whether that might just be, their inability to articulate what their overall role is, but you may actually be working with a professional that is more of an evidence collector. And in those circumstances, you can't really make the argument. But in most circumstances, you're going to be able to make this argument that the SANE is not an arm of law enforcement, that their primary position is to be there to provide patient care. And all of that is really important when we get to the legal side of things about why these statements are admissible and why they are relevant to the treatment and diagnosis of this patient they're caring for.
Yes, absolutely. That's why we want law enforcement to bring us patients, regardless of visible injury, regardless of evidence collection timeframe. And prosecutors may be in a very unique position to encourage that. If you've got law enforcement who's on scene and calling a prosecutor for advice and guidance on how to proceed, especially with these complex trafficking cases, for a prosecutor to say, I want that victim, or I want those victims to have exams tonight or at the soonest possible moment, regardless of evidence collection, because they'll listen to you.
That's right. Leverage that perceived power, that real power. Okay, so let's now get into a little bit more of that legal side of things. So what are the statements that are going to be made to a SANE possibly in the course of this interaction? So there's going to be statements that are made as part of that disclosure of history, right? That they're included in all the medical exams. They're important because they guide the then subsequent physical exam. They're necessary for any prescription of medication, to figure out what lab tests might be needed, and to really form the ultimate diagnosis that's required. So that's the arguments that you're making for why these statements are appropriate under the medical testimony exception, hearsay exception. And then the discharge piece, which is often where we've seen a little bit more difficulty. And most of that difficulty, if you look at the case law that says, this information is not relevant, I would say that was really because the prosecutor wasn't able to articulate strongly enough the key pieces of why that discharge is a part of the medical treatment that a SANE provides. And so we want to be highlighting things like the patient's safety is a medical priority, that any discharge plan is dependent on where that patient is being discharged to or who they're being discharged to. I know, Kim, you sometimes say, I'll ask if they're living in a place that has stairs for a patient that I need to send home on crutches. And that this is an analogy that we might be able to make to demonstrate to the court why these types of questions about where and who they're being discharged to are absolutely relevant to the care that's provided.
Yeah, that's why we ask questions too about the perpetrator or perpetrators, because the more we know about them, the more we know some of what our patient is at risk of, especially around things like hepatitis, HIV, and ongoing violence.
Mm-hmm. And so that's kind of that last piece, is trying to make sure that we have a really strong sense of the SANE's role so that we can articulate it to the court in a way that demonstrates that these questions about identity, these questions that go towards discharge, are pertinent to their care and their follow-up care. So this is the federal definition that we've been talking about. This is the another exception that's a hearsay exception that might be relevant to statements made in this setting. So this is the then existing condition hearsay exception. This is the federal rule. It might look slightly different in your individual states, but essentially they mirror one another. And this is a statement that The declarant, in this case, it would be the victim survivor, is saying that is illustrating their existing state of mind. So right now, I'm hungry. That would be something that would fit under this exception, or that hurts. So emotional, sensory, or physical condition, including mental feelings, pain, or body health. I will say this federal definition is a little bit on the broad side when I look at other states. But you want to look at sometimes it's called then existing physical or mental status or condition. And you'll see this. It doesn't refer to anything from memory or a past belief. But those statements, when we're talking about assault histories, those are the ones that we are going to ask the court to admit under a medical diagnosis or treatment hearsay exception. And the two key pieces of this is that the statement has to be made for or reasonably pertinent to a medical diagnosis or treatment. And it includes medical history, past or present symptoms or sensations, their inception, or their general cause. And so this is really where we're relying on this exception to get in our assault history and even maybe our medical history under this exception. And this is some case law that talks about, okay, where are the bounds of this? So this is a case out of Washington where it says, although statements attributing fault, so who did this to you, are generally not relevant to the diagnosis or treatment, when we're talking about statements attributing fault to an abuser in a domestic violence case, there are exceptions because the identity of the abuser is pertinent and necessary to the victim's treatment. So, this is the sort of language and case that I would then make an analogy to when I'm talking about a trafficking situation where the relationship between the abuser, the exploiter, and the victim is pertinent to their ongoing safety. Right. And I would even argue that it's not just in cases where the relationship is familial or looks like an intimate partner relationship, or at least a cohabitation relationship, but this could extend to a worker employee, or excuse me, employer employee relationship that might be relevant in a labor trafficking case, because it's that relationship that this case really is talking about. Another case, kind of a seminal case that we use a lot to demonstrate the case law itself, the court really made a great record of why they admitted the statements they did. And frankly, it gives us all a little bit of a roadmap to how we should make our arguments when we're asking for the identity of the offender to be entered into evidence under this exception. In this particular case, the SANE provided a medical forensic exam. It was a rape victim. As part of that exam, the victim identified her rapist. And ultimately, that victim died before the trial. I don't think it was related to the assault, but don't hold me to that. But at the time they wanted to go forward with the case, they had the identity, they had this statement. And so they did a really good job of prepping the SANE and making the appropriate arguments. And so in this case, the SANE was able to testify that why this information at the time was medically necessary, relying on the discharge planning as being part of that exam and their care to the patient. And ultimately that SANE was allowed to testify to the statements because the court ruled they were not an arm of law enforcement. The statements about identity were made for the purposes of medical treatment, and it was non-testimonial. And you'll find that most, if not all, statements to medical professionals are going to be deemed non-testimonial under Crawford. Okay, so you guys, if you have any questions as we go through this, please put them in the chat. One other hearsay exception that may be relevant to cases where you have medical documentation is the recorded recollection exception. And that really allows folks to use the documentation that they made at the time of their exam. So Kim is making that documentation as the same time or immediately after she's providing that medical care, but now she may need to refresh her recollection or to make sure that it's what is entered into evidence is accurately reflecting the knowledge at the time of the exam. So there's this exception about recorded recollection. And I'm asked, Kim, I know you probably have an amazing memory and you never have to rely upon this, but have you, when you testified, have the prosecutors use this exception to get in the record itself that you've made as you documented the exam?
You know, there's you when we're prepping for trial or for to be a witness, there are things that you should have committed to memory, but there's no way you can memorize your entire interaction. So if I'm on the stand and I know I documented it, but I can't remember, I'll say, well, I know I documented it, but I'm not remembering right now. Is that what you're asking?
Yeah, exactly.
Yeah. And then, you know, any one of you are probably already saying in your head, if I provided you a record of your documentation from this exam, would it clearly, what do you say, refresh your memory?
Yes.
Mhm.
Which is a slightly different way to get evidence in. The recorded recollection, you may actually get the report in, or it may be able to be read into evidence. When we're refreshing a recollection, we're only allowing you an opportunity to look at it, lay it aside, and then your memory would have been refreshed, and now you are just answering my questions.
Yes.
Jennifer in the note says her favorite, I'm guessing this is a comment or favorite question you ask, which is, may I refer to my notes? And I appreciate that, instead of, struggling and, and that's part of that prep too, is letting your witness, like, hey, listen, if you don't remember, if you need to look, ask me, we can make that happen during your testimony. I'd rather you have it correctly before the jury. The other thing I just like to say is that, and I know that SANEs are very good at this, but one of the things prosecutors might not readily identify as really important is the demeanor evidence. First off, demeanor evidence is always admissible. It's not hearsay. We're talking about, what did you see? What did somebody look like? What was their, body language? And then if that's documented, and it should be by the SANE, it can help us as prosecutors then provide that context. And it actually is great evidence if perhaps we're trying to strategize how we'll explain to the jury what might look like an inconsistent statement. Let's say I have a statement from the law enforcement officer who's documented demeanor, and the demeanor was angry, arms closed across their chest, not looking in my direction. And then their statement is this sort of concise, not very much disclosed in that statement. And then you can contrast that with a statement maybe provided to a SANE, where the SANE is documenting that, at the beginning of the exam, the patient appeared closed off and not willing to talk. By the end of the exam, the patient had relaxed. And I'm just making this up on the spot, but what you could do is you sort of compare and contrast, which then of course the jury will understand, well, this makes a lot of sense of why these statements also are a little bit different in how much was disclosed as far as that goes. It can also be powerful for other exceptions to hearsay. So for example, law enforcement, we always want them to be documenting demeanor because that might be relevant to our arguments about whether this qualifies as an excited utterance or not. But if this is documented and we can look through it and we can talk to SANEs in advance, we may even be able to present it as powerful evidence of fear, trauma, embarrassment, shame, feelings of helplessness. And all of that demeanor evidence can go a long way to us to really recreate the reality of what this experience was like for the victim survivors we're working with. And so you've got that, and then you've got the SANE talking, educating the court about all of this exam and how long it takes and how careful they are with making sure they're getting consent at every stage and how they're educating their patient at every stage. This could really be a big highlight to your trial and how powerful this evidence can be. but we're going to expect those inconsistencies. There's lots of reasons for them. Everything from that trust to that trauma. It may be influenced by the use or the lack of using drugs or alcohol at the time the statement was taken. You also want to be thinking about culture and shame and just the different roles and settings where statements were taken. So again, incumbent on the prosecutor to be strategizing how to deal with this, how to present this effectively to the court, not a job of the victims to overcome. And definitely the response should not be, well, then I guess we'll just not talk to the victim survivor again, because we don't want to make another inconsistent statement, which we've seen as well. No, let's work with this victim, and then it's our job to present the evidence. So the SANE as an educator, and this can be to the patient, to their allied professionals if they're working collaboratively in their community, but also to the victim survivor as well. So Kim covered a lot of this, but I would want to make sure that while I'm presenting this evidence, I'm also educating the jury about this. So a big role that you have, and I never really thought, I think you were the first one that told me, Kim, that, you know, a nurse's job is really an educator for many parts of it.
Yeah, that's what we do every day, whether we're educating our patient on what's happening, their family, explaining why things are happening. I think back to when I was a labor and delivery nurse. All I did was educate. This is what the baby strip means. Here's what's going to happen next. This is what I need you to do. It's what we do every day with every interaction that we have. Every patient that we see, we have to give discharge instructions to, or take home instructions. So when we think of our testimony, I'll frequently tell nurses who are new to testimony, you're not on trial. You're a witness. You've done nothing wrong. You're going in and you're educating. When you can look at that judge, the panel, the jury, whatever the term is, of the people in the courtroom, just as your patients, and you're explaining, what is an exam? What are the components of an exam? Why do you do them? What's the rationale behind why you ask a history? What happened with this patient? What was your findings? All you're doing is educating about what you do every day. It takes some of the fear out of testimony, I think.
Absolutely. So the other thing I'd like to say is, you know, don't save your SANEs for like, okay, this is actually going to trial. Now I need to make sure I've got the SANE ready to testify. But they should be integrated into your response much more collaboratively throughout the entirety of the response. SANEs can provide input and education that can affect how we investigate cases. Let's think about a labor trafficking case where there's exposure to dangerous chemicals. What should I be looking for? How could I explain the danger of this? So many things about the investigation, educating us on the lack of injury, or I think I said in the last slide there, sort of the difference between a history and findings and why that might be there, so that when we're making our charging decisions, we're doing that informed from the medical perspective, and we're not assuming something that really isn't medically true. I feel like I used to just get the medical records and I would just think I could translate them and I could just understand medical records. No, take advantage of your partners and say, look, walk me through this. And you may need to do that, you know, in preparation for trial, but oftentimes that might be something you want to do earlier in your case when you're still investigating or you're still trying to decide what charges are appropriate. And then of course the trial itself. So, and how key that is to do that. But I want to take a couple of moments to really hone in on the purpose of this series, which is thinking about how can prosecutors in our role enhance collaboration with SANEs and increase victims' access to medical care. So if you saw the first webinar in our series, we sort of pulled out 4 things that prosecutors can do in their role. One is that they are a great collaborator. They can also bring people to the table and convene new partners in a jurisdiction. They can be a conduit to services. And then very sadly, it's a soft C instead of a hard C. Collaborator, convener, conduit, but they can also be a change maker. And they can affect how we make changes and for the better. So as we're working with SANEs, how do we do that? First off, that collaboration piece. Are you working in a task force, whether really formalized or maybe less formalized, some sort of multidisciplinary or community response? How can we as prosecutors bring that task force together, be present, maybe bring in some education to the different partners, and then think about how we're going to use this education, this enhanced education that we have to better collaborate and to better use really this what is a great resource within our communities. And I know, Kim, you work on task forces and you have in the past, I'm sure you still do now, how key it is to have the multidisciplinary setting where you're learning together, you're learning from one another, and then you're building a response, not just based on one discipline's sort of thought process, but collaboratively.
Sure. And you're taking each other's needs and like what you need your outcomes to be, you're taking it into consideration. And when we're not trying to be a different discipline, but when you understand the other components of this community response, sometimes it just makes you better at your job and the way you do it.
Yeah. So how, in a collaborative sense, can we better provide that or facilitate that access? While still thinking about the autonomy of the victim, consenting to that and what their fears and concerns may be, and have as much control over that as possible. But I think we sometimes just sort of, intersect, law enforcement might intersect with the victim and immediately just say, hey, do you want medical care? And it's just so easy in that sense that someone would be like, no. So how can we better think about our protocols to provide meaningful access, and ask the question in a different way, make it a much more accessible thing to have, like, hey, let's just go to the, let's go to the hospital or a clinical setting. Let's go there. Let's see if you want to talk to a nurse. And you guys can make that decision there, instead of making it really something that the victim has to really almost push to gain access to.
Sure, Jane, I just want to share a quick experience I had many years ago when we first had a human trafficking task force where I lived and worked. I was taking care of a victim of sex trafficking, and she had some really severe mental health issues, and we were having a difficult time asking her questions and her answering kind of a lot of gibberish. And what it came down to, this very good patrol officer, and I figured out that the traffickers still had her little dog. And she could not focus on anything because she was so afraid they were hurting this little dog. And this patrol officer called in the trafficking investigator, and they came up with a plan, and they went to where the traffickers were. And even then, they had the prosecutor's permission. They didn't have enough yet to arrest or charge, but they kind of just marched in and grabbed the dog and brought the dog to the hospital. And as soon as we put that little dog in her lap, she de-escalated, she calmed down, she was able to answer questions, but that was all because the team knew each other, and we were able to use each other, and the prosecutor kind of gave permission for this, unusual intervention to occur. And it was just a really beautiful, outcome, at least in that moment.
That's a great example of, really assessing the victim's concerns and fears and not assuming what's happening when somebody is appearing to not be, open to disclosing. That might not have anything to do with them, not wanting to,
cooperate.
Yeah, exactly. We may see it as that. Yeah, we may see it as that. It's really just like, I can't even think until I have my dog here with me.
I know. And how would you ever know to ask that question? Like, it's not going to be on a checklist of questions you ask, but it really came down to that patrol officer understanding, like, she's afraid of something that we're not pinpointing.
Yeah. Wow. Great job, patrol officer.
Yeah.
But also thinking about what does the victim need? The victim may need some crisis intervention right at that moment. The advocacy support, so incredibly valuable to the overall response. And then thinking about what are our protocols going to be when we're looking at a case that is drug facilitated sexual assault that's related to human trafficking. So a lot to kind of dive into as a collaborative team. So preparing for trial, we've woven this in as we've talked today. But again, I would just say, don't assume the SANE is like a professional witness just because they've testified before or because they have this role as a sexual assault nurse examiner that obviously overlaps with the criminal justice system. Also think about the schedules that your SANEs may have. I know that you probably, most SANEs have like a full-time gig and then they are on call or rotation for SANEs that might be like overnight. Is that right, Kim?
Sometimes it just depends, but yes. And many of them have other jobs in addition to the SANE call that they take. So they're juggling a lot of things.
Yeah. So schedule something, excuse me, at their convenience. Make sure it's not on the eve of trial, well before trial, maybe even before charging a case, if some of the medical evidence is related to that. Review the case together. Talk about, hey, these are the pieces that I think are relevant. These are the pieces that I want to focus on in our testimony. What do you think is relevant? When you were working with this patient, what did you think was the most relevant to their trafficking experience? And oftentimes, I'm sure, Kim, you have this experience that you're going to be pointing out things that I never even thought of as the prosecutor.
And vice versa, for sure. It's just two very different perspectives that can really benefit one another.
Yeah. And then also talk about and explain that SANEs often will be testifying both as a fact and as an expert witness, which is a unique position to be in. They're fact witnesses is they're talking about what they did, what they observed, the statements that they can testify to under the hearsay exception. But then you're also going to be asking them for findings based on their observations. That's one type of expertise. And you then also may be asking them if they have the requisite expertise to maybe even talk about expertise on trauma and common responses to trauma. So be prepared to think through and strategize based on the SANE's experience and expertise, but also what you're going to be needed in a case.
And you're probably going to encounter SANEs that are really uncomfortable when you say you want to qualify them as an expert, but gently remind them that they are experts and that they will be more effective as educators in the courtroom if they are qualified as experts. I actually think that new SANEs who are new at testimony do much better as expert witnesses than fact witnesses. It gives them a little bit more freedom to educate.
Yeah, kind of. I think it would take off some of that pressure because once they got into a rhythm, it might be they can just kind of fall into their, what they do every day, like you explained, instead of this very foreign atmosphere of being on a witness stand.
Yeah.
You're going to want to work fairly with both sides. So obviously defense should be provided adequate notice of their testimony. If the expertise is going to be brought out, we need the documentation, we need the CV, the expert report. You can coordinate with the defense if they need to do an interview or a deposition. I would always inform, offer, or just force myself into those situations because I want to be present during that interview or that deposition where the defense is asking questions. I'm going to learn something probably that I didn't know already about the actual facts of the case, but I might also get a preview into, what cross-examination is going to look like. Or even better yet, what is the defense's theory of the case? What is their defense going to be? So it's actually a great opportunity for prosecutors to be part of that process. And of course, the court always appreciates when we're being really, open and helping out with the defense having access to the witnesses. We talked about the different pieces of the testimony as the fact and as the expert. Here are just a little bit more of the details of what would fall under the fact. So I've never seen it, but there could be possibly a situation where your SANE is deemed not to be able to testify as an expert witness. That shouldn't really happen, even if you have an inexperienced SANE. The training, their education should allow them to do that. But we know some courts, are stricter than others. If this is not a normal process in that court, it may just be something that court needs to be educated about. Again, we can help with that, some of that capacity building for would-be witnesses. So that's a place where you can reach out. But just in case, you can still use the SANE to explain the exam, all of the observations, to describe the demeanor and the admissible statements as a fact witness. And then as an expert, you're really going to maybe try to get a lot more in front of the jury about what are those risks of both sex and labor trafficking, what were the findings and interpretations, and then that question of were your findings consistent with the patient's history, and then allowing that expert to explain any research or any explanation which would educate the jury about the lack of injury, of an expected injury. And then of course, even some nurses, some SANEs are going to be able to testify as to those various presentations of trauma. This is the expert witness federal rule. We have it here as a reference. Most states mirror this completely. I always like to point out that a witness can be qualified as an expert in many different ways, including experience, of course, education, training, and also that an expert can have scientific or technical expertise, which most judges are going to maybe be familiar with because they'll have had a DNA expert or a fingerprint expert. But this may fall in, especially when we're talking about common responses to trauma or common victim behavior, that may fall into the specialized knowledge bucket. And that's absolutely appropriate under the rules of evidence as well. And then this is the expert testimony sort of foundation here, that there is no more certain test for determining when experts may be used than the common sense inquiry, which is whether the untrained layman would be qualified to determine intelligently and to the best degree the particular issue without enlightenment from those having specialized understanding of the subject. So will this SANE provide the jury additional information, context, and education that's going to help the jury make the ultimate determination, which they're only responsible for, which is things like victim credibility and the establishment of the elements of the case. And another thing to kind of work through is, be really clear. The best testimony is really plainly worded. We don't need scientific and very, I don't know, people sometimes I feel tend to want to discuss things more professionally, if that's the right word. But really, we want the expert witnesses to come off like the trusted nurses that they are. The trusted nurses that your juries are going to want to trust immediately, that they're used to, that they've had a lifetime of hopefully really positive experiences with. So plain worded, simple, concise, and also be able to articulate maybe a peer review process that's in place there. As a practitioner, asking the questions, I always use words like us and we, and I put myself in the position almost physically as well as another member of that jury. And then I want to ask that nurse questions from the perspective of what I think the jury wants to ask. So, hey, can you tell us more about that? Or can you explain to us why you do that? Those are simple, plain worded questions, and they also invite, hopefully, simple, understandable, plain worded responses. I don't know if you have any tips for the SANE would-be witnesses.
Just a few. Talk to the jury just like you explain things to the patient. So, if you're explaining what a colposcope is, just do it the same way you do to a patient, because you're good at it. It's comfortable. It is plain. It's simple. It's concise and accurate. My best piece of advice, no matter how experienced you are, when you're asked a question, repeat it in your head before you answer. Too often we feel like we need to spit out the perfect answer as an expert. If you take the half a second it takes to repeat it, you kind of just collect yourself, you turn and you answer a little bit better.
That's good advice in everyday life, Kim. So going forward, as prosecutors are, as members of a multidisciplinary response to sex and labor trafficking, we need to appreciate those short, long-term health consequences, both physically and psychologically, and need to recognize the risks that they're taking and also the potential consequences. And then really work with medical experts. Think of ways to integrate that more meaningfully into the work that you're doing, whether that's providing opportunities as the convener that you are as a prosecutor to bring in cross-training where the SANEs can come in and educate the other partners about the work that they do, about how they perform the jobs that they do. But educate yourself first and foremost, your other partners, and then ultimately you're going to use that same strategy to educate your judges and jury. And then litigate the admission of expert and fact witness testimony. This is a place where if you're having issues, if you want help, maybe briefing this because it's not a standard practice in your jurisdiction and you want to implement it, but you think maybe the judges are going to maybe not be so open to it, this is a place where Equitas can really help. There are lots of resources that are available through our website. I know we've been pushing that, of course, IAFN, but also our funders, our Office for Victims of Crime. They fund a ton of training and technical assistance. Much of it is online and accessible to you, including things like the Task Force e-guide, development and operations roadmap, and through their collaboration with the International Association of Chiefs of Police. There's a learning portal that's really specific to law enforcement responses as well as multidisciplinary ones. So thank you very much. We've put in the chat a link to our evaluation. I think it's literally 3 questions with multiple choice answers and a place for you to make any comments. We'd really appreciate that. I know our funder would as well. This is my information. I just want to thank Kim. It's always a pleasure. I learn something every time we present together. So thank you. I'll let you have your closing argument is what I was going to say, your closing remarks.
Yes, thank you. I learned something every time too, Jane. It's just an honor to be a part of this. Please reach out if you have questions, especially if you have forensic nurses in your area that are interested in further trafficking, how to provide in-depth exams for patients who have experienced trafficking. I can point them in the direction of some free and good training. So thank you. And thank you all for what you do in your communities.
Yeah, absolutely.